Hello, I am Bizrah, consultant ENT facial plastic surgeon. I published my textbook on rhinoplasty, facial plastic surgery in 2002. The book has more than 500 pages and 1,000 illustrations. The textbook was forwarded by the presidents of the American and European Academies of Facial Plastic Surgery and was distributed worldwide. I hope you find these videos are very interesting. It's designed mainly for surgeons, plastic surgeons and ENT and facial plastic surgeons. It's professional and educational. It presents my approach, my school, the Bizrah School of Rhinoplasty. You are most welcome and I hope you find it very interesting. This is interesting case of Droopy tip. As you see there, the tip is going down with short columella. So the tip is under projected and is pushed down because the lateral cross there is quite long and pushing the tip structure down. And the patient has got like a hump, which I would call it a false hump. So should not be touched. Once we get the tip projection, the dorsum will become straight. So I hope you now enjoy watching this very interesting case. As you see, as we said, the Droopy tip, and look at the front of you. The nose is dropping down, almost occupying the upper half of his upper lip, and also as you see down there. So the procedure will include a tip-plasty, will include a lateral cura overlay technique and tongue-in groove technique. Of course, starting with septal graft. The procedure will be done under local sedation. I hope you enjoyed watching the procedure. I'm going to start now the procedure, and as you have seen, the patient has got the Droopy tip, under projected tip, and this is called false hump because once you got the tip slightly up, the hump will disappear. So you have to be very careful about this patient. You have to identify between the true hump and the false hump. So try now start obtaining septal graft. Can you take the table slide to the right, please? So we have to make our incision just on the caudal septum, just 2 millimeters behind the edge. Enough.
Thank you.
And we need to identify the right plane. You have to get to the right plane, very important. If you identify the right plane, then you make your life easy. I think we are on the right plane now. You see now the white cartilage inside. The white cartilage means I'm on the right plane. And then if you see, find the septum, it will run easily because I'm on the right plane and I'm just elevated the left pericondylar flap left in a few seconds. You can see I'm on the right plane. And then I will just go for about just over 1 centimeter behind the caudal septum and score the cartilage and suction, please. Now we go to the other side. Oh, okay. Give me a knife again.
Knife. Just like that.
Just to identify the right plane on the other side. I think we are on the right plane. On the other side now. And this is now the cartilage in the middle. As you see, in less than 2 minutes, we elevated the two pericondylar flap and the cartilage in the middle because we were on the right plane. And the nose was very well prepared. As you see, there is no bleeding at all. And patient has got nice sedation. The procedure under local and sedation. So we'll get a septal graft, which we're going to use for as tip graft columellar strut. Okay. Just removing some kink cartilage. Okay, that's fine, it's enough. Kill him again. Any small pieces of cartilage and once we can just get out. Okay. Now we start our rhinoplasty. As we always said, we start to work mainly in the midline. So we are at the kefir cross midway and then towards the midline. Again at this is the cross halfway and towards the midline, as you see. So avoid lateral undermining and lateral dissections. There is no point to go to the lateral side of the nose because your main problem is always in the around the midline. So you stay around the midline of the nose. And then with blunt scissors, keep your hand down on the bone and cartilage to stay below the mass and below the aponeurosis. So now, to reduce this supraolar fullness, there we need to trim part of the curvature of the upper lateral cartilage, not really the upper lateral cartilage, only the curvature. So as you see now, only the curvature of the upper lateral cartilage. So we get the mucosa down, and we just trim the curvature bar, curved part of the upper lateral cartilage. So we kept, as you see, the upper lateral cartilage intact. Again, other side. This will reduce the fullness here. Because you see the fullness there, it will be reduced by trimming the curvature of the upper lateral cartilage. Again, get the mucosa down. Get the mucosa down. And trim only the cartilaginous bit, the curvature only. Only the curvature, you see. So the upper lateral cartilage, as you see, is kept intact with its full attachment to the dorsum septum. Okay. This will help you to reduce the supraolar fullness. Now we start our tiplasty. We'll look at the tip defining point. This is the tip defining point, quite clear. There is a junction between the intermediate crura and the lateral crura. You see now how the mucosa coming to mucosa is very nicely there. And we cut obliquely. Don't borrow any part of the lateral cross. With this technique, please do never borrow any part of the lateral cross. You don't need. So keep the full integrity of the lateral cross. Again, on this side, we just make an oblique cut as the junction between lateral cross and medial crura, intermediate crura, and again, don't borrow any part of the lateral cross. Keep the lateral cross full and intact. Then we'll go around, try to dissect now. It's going to be short intermediate crura because the lateral cross is mainly the alar cartilage is mainly lateral cross because the lateral cross is quite long. So this is now the two intermediate crura. So we go in between. And we make a bucket between the two medial crura, as you see. Okay, it's very short because lateral cross is the alar cartilage is mainly lateral cross. So he has got very short intermediate and medial crura. So we go to the cartilage there now, which we have, and we'll obtain a tip graft. As you see, it's a tip graft here, and a columellar strut. So we get the columellar strut now. And we suture the three structures together. The intermediate crura and the columnar stuff together. Very tiny cartilage because the patient has got droopy tip. So the main structure here is the long gutter cross. That's the main structure if we have. We will deal with it in due course. Now another bucket on the caudal end of the 2 medial crura, another bucket there, and we'll insert our tip cartilage. We need a nice good piece because we need to hold the tip up. The patient has got short columella and the projected tip, a droopy tip. So we need good tip support to achieve adequate tip projection. Okay. And now we'll make the bucket at the back here to prepare for the tongue end groove technique. Make the bucket between the 2 medial crura and make a place for the caudal septum to be fitted in. So we are between the 2 medial crura at the back side in order to get the caudal septum to go in between the 2 medial crura backwards. So the tongue end groove technique. And now we get also make the caudal septum ready to be accommodated in between the 2 medial crura from the other side. Section. This is the caudal septum. The caudal septum, so we'll just expose the other bar for about maybe half centimeter. You need to fully curve.
Fully curve.
Just remove any excess soft tissues from there. See, now we got nice caudal septum here. We go in between the 2 medial crura. We make again, remove this excess of tissue from the other side. So we're making the caudal septum ready to go in between the 2 medial crura. You see, now once we push like this, because you have got a longer cross, it will still not achieve our goal. So we have to deal with the longer cross. So we have to do that crura overlay technique in order to shorten the lateral cross and rotate up the lateral cross. So if you suture now and keep it like this, then by the tension force after a few months, the tip will still go down. So we'll treat that, we'll manage the lateral cross first, and then we'll go back to the tongue end groove technique. So this is the lateral cross. Lateral cross there. We just refresh the edges. You see, we're not excise only. You see only 0.2 of the millimeter, and we go halfway of the lateral cross. See, the lateral cross is intact, absolutely intact, no marginal incision, no exposure.
Fine, sure.
We do a lateral cross overlay technique intranasally. We go just halfway, and as you see, we go halfway, open you, and then you just Go back, turn your scissor 90 degree and cut the cartilage. And this is what overlap now. You see overlap, you see the overlap in here. And just remove the sharp edges. So the overlap cartilage now will help in shortening the lateral. See the difference between two sides now. This side is fine. This side is still bulging and pushing the tip down. And this side is fine because now the lateral cura will be easy to rotate and being shortened. So it will help us in achieving our goals, in treating the droopy tip. And we just have to just maybe do some more skin there. And then now we have to lock it with suture. Look what we achieved now with suture now. Okay. So you can see that you can do anything intranasally. You don't have to do external approach to do the Yatakura overlay technique. So you can do the tongue end groove technique endonasally. You can do the Yatakas overlay technique endonasally. You can do any technique endonasally. So it's not important how you get in. What's important is what you do when you are in. So you see now the overlapped Yatakas there, very clear. It's been locked with this suture to make sure that it will not spread again. So this technique will shorten and rotate that across and achieve our goals in managing the droopy tip. You see the difference between the two sides now from above. This one is the fullness has gone and the nose is rotated slightly, and this one still there is fullness and slightly down. So we go and do the same on the other side. We'll identify, this is the lateral cast, we see intact, no marginal incision, no exposure. We go halfway. Just give me the sharp scissors. And we'll do that Kura over here technique, as you see, under the skin, and then rotate your scissor 90 degrees and cut. You see, this is the overlapped cartilage, and just get rid of the sharp edges. Okay, and now we lock it with suture again, as we do the other side. To secure our rotation. And the shortening of the lateral cross. You see the folded cartilage, the overlapped cartilage is secured. So we make sure that the lateral cross being shortened and rotated in order to achieve our goals in management of the droopy tip. And this is all being done, as you see, intranasally. Okay. Now we'll go and do there's no need for the nasal bag. The patient is not bleeding. See the procedure under local with sedation. And the patient nicely tolerating the procedure. Give me marking pen. I will just mark where is my suture going to be. Okay. So the aim of this suture is to get the aim of this suture is to get the two lateral cross around the caudal septum. So this is a tongue end groove technique, getting the two lateral cross around the caudal septum. Okay. So this is the what the tractor is here. You can So we are halfway on that class, on the medial cura, and then back to the septum. And then we'll make sure the septum goes into it's in the midline, and then going back to the medial cura on this side. Okay, one more suture. One more suture just to secure our, one more septocolumella suture to secure our tongue and groove technique. I use monoclear for this stuff. I use monoclear usually.
You want monoclear?
Okay, خلاص finish. You know, for the second step. So my finger like this, I make sure that the caudal septum is in between the two medial cura. Do some fine touch. About to finish. Some small bulge in there I need to deal with. See where the patient has got this bulge. Yeah, looks fine. Yeah. It's almost disappeared now. It looks fine actually. Just one more suture volume. One more suture volume.
One more prolene.
Okay. Just one more suture to secure. I make it slightly high up to get the tip back as much as I can. Cut here, this is not good. Just click on it again. Okay.
Move the switch here. Let me cut, move the switch here.
And remove.
Okay, we don't need it actually. Let me move it now.
And
Let's do it again. Give me Berlin or monoclean is fine. Yes. If you look at the side view now and you see how much improvement we achieved. You see the straight dorsum now compared before it was this false hump, the tip projection and the angle between the nose and the columella, and the angle between the nose and the columella, you see a very nice angle. It was before acute angle here. If you look there and you see the acute angle there, and now compare with the short columella, compare now with the stretched columella, with this very nicely stretched columella and the open angle between the nose and the lip. Okay. Give me one more session. See now, very nice profile. Very nice profile. Okay. But now this patient, we need additional maneuver now because this patient, when he laughs and talks, the nose drops more down toward his upper lip. So we need to reduce the power of this muscle between his lip and his nose, the depressor nasi muscle. And we do something like, we call it like a nose lift. It's similar to the cheek lift or molar lift. So we go and around, this is the depressor septinasi muscle. You see, I'm just remove it from the bone. Again, on the other side, cut and remove the insertion from the bone and get the embryostom elevator and remove the muscle insertion and go slightly around the aperture up to about halfway and get all the muscle up. Elevate all the muscle and reduce the attachment of the muscle to the bony maxilla. So around the aperture, as you see, and up. You see where is my sector now here? Almost just halfway or less than halfway. So you're getting all the muscle up, muscle insertion up, and this will actually mobilize the insertion of all of the muscle of the nose slightly up. So you are shifting the insertion slightly up. And you see now we reduce the tension from the nose. If you look at the side now, we reduce the tension. So there is less tension, less muscle pullness down. So this is called like a nose lift, like what we do when we do cheek lift in face lift or molar lift. So this will give us very good result and preserve our result. So with this suture now, to make sure that the muscles will stay up and not to be inserted in the same place, or to be inserted to slightly a higher level. And we go backward as much as we can. And you see now here the effect of this suture, that it lifts the muscle up. So when it lifts the muscle up, it will make the insertion, the new insertion of the muscles in a slightly a higher level. So what we call it like exactly the same, like cheek lift, nose lift. It's which I modified, and actually it's given very excellent result and long-lasting result, because if you do what we have done, the full tip-blasty through Indonesian or external approach, and you still have a very strong muscle that's pulling the nose down, so after 6 months or 1 year, that you find the patient coming back and telling you, I mean, look, my nose is back down and my tip is back down and it's almost the same. So this is essential maneuver at the end to preserve the tip rotation and the projection that you achieved during surgery. So this will shift the maxillary nasal muscle to slightly a higher degree and achieve more lift for you and reduce the tension on the nose. Okay. Can you remove my... How many minutes?
29 minutes.
So this operation now lasted about 29 minutes, so almost actually 30 minutes. Under local with sedation, we managed and we treated the drooped tip by doing modified dome division, tip-blasty, columnar strut, tip graft, lateral cura overlay technique, tongue in groove technique, and dividing the brachio-septal nasal muscle and nose lift. And the patient tolerated the procedure very nicely under local with sedation. As you see now, the result, if you look at the patient now there, at the droopy tip there, the false hum, the short columella, the under projected tip, look at this quite obvious here, and move and look at the side view now, and how much we achieve nice tip projection to the right angle. You look now, see the nice columella, how columella being stretched, the nice tip projection, the nice tip rotation at this angle. It was acute angle now, an open angle, and now very straight dorsum. The patient has got like a hum before, it was a false hum, it's not true hum. So once we got the tip slightly up, the hum has disappeared. And you see now from down below the symmetry and the nice tip definition, and from up, you see very straight dorsum. So again, from the side view, very nice profile compared to the profile before. So we treated and managed the droopy tip. This is Bashar Bizrah, consultant ENT facial plastic surgeons from BMC and Seed Centers. Thank you.